Hi, everyone. Thanks for joining. We're just going to give it a couple more minutes and let some people continue to come in. But I just wanted to say welcome. Thank you so much for being here, and just give us like another minute or two. Okay, looks like it's slowed down with people joining, so we'll go ahead and get started. Thank you, everyone, for joining us tonight. My name is Kristen Bellamy. I'm the physician relations rep for Rothman in New Jersey, so I am the person that can help you with your appointments or any questions you may have in terms of scheduling, anything like that with Rothman. And we are here with Dr. Parekh, who is one of our foot and ankle surgeons. We are so lucky to have him. He's been with us about 2 years. He is a board certified fellowship trained orthopedic surgeon who specializes in the treatment and conditions of the foot and ankle. He sees patients in our Bensalem, PA office, our Newtown, PA office, as well as our Princeton, New Jersey office. I'll turn it over to him. He is the one that everyone's here to see. And I'll just remind you that we are recording this session and it will be emailed out to you within, it's usually about 6 days until it gets out to you. So if you have to jump off early, go ahead and jump off and we'll make sure you get in your email. Any questions you may have, drop them in the chat and we will address those at the end. Thank
Awesome.
you. Go ahead.
Thanks, Kristen. And thanks everybody for joining live. And if you hear this later on, thanks for joining later on. Again, like Kristen said, as you have questions, feel free to drop it in the chat box. We want to make this as highly interactive and informative as possible. So if you have questions, feel free to drop them in there. So I am a foot and ankle specialist. I am an orthopedic surgeon. I've been in practice for about 20 years. I was down in North Carolina for 17 years of my career and jumped up here to Raleigh, to Rothman about 2 years ago. As Kristen said, in the Bensalem, Newtown, and Princeton offices. I do take care of a lot of foot and ankle sports injuries. Actually, a lot of sports injuries happen to be foot and ankle. In fact, over 50% of them involve lower extremities, of which the majority of them are foot and ankle. So we do see a lot of sports of all ages, from the pediatrics, 9-year-olds, all the way up to the 90-plus-year-olds. And so we're going to talk about some of the more common spring and summer injuries as we launch into the spring. Why is this not? All right. Here are my conflicts of interest, none of which are relevant for this talk today. So as we start getting into the spring and summer, a lot of us have been dormant through the cold weather, and many of us are starting to try to be more active, which means more outdoor activities, and thinking about foot and ankle in the context of the number of injuries that can happen is important. So today I'm just going to review some of the more common injuries. This is by no means an exhaustive list of foot and ankle sports injuries, but it's the more interesting ones that you may have heard or experienced yourself. And so I thought it would be worth talking about these in today's talk. And we'll talk about some conservative and surgical treatment options. So a few years ago, and in fact, almost every season since the time that he's been in the career, been in the NBA, Steph Curry has had one of these type of ankle injuries where you see him roll on that ankle, and it's even painful to watch the injury. But if you look at his right ankle, you'll see that it really twists inwards and causes him a lot of pain. And usually he gets knocked out for a few weeks. So this is your common ankle sprain. And in the US alone, you see about 25,000 ankle sprains a day. Thankfully, the vast majority of them don't need medical attention. Otherwise, just with ankle sprains in the healthcare system, we would be inundated and would really be overflowing with just ankle sprains. Now, the one you saw Steph Curry have, and the one that's the most common, is called the inversion injury, common in running sports or cutting sports, especially basketball or soccer. But you can see it in anything, and you can actually see it even when you're walking and you feel a pebble on the bottom of your foot, and you twist your ankle and you roll it inwards. That's an inversion injury. We'll talk about that a little bit more. The less common one is called an eversion injury. So instead of rolling your foot in, you're rolling it out, and you will sprain another set of ligaments on the inner part of your ankle. So when you roll it in, that's called an inversion. And if you look at this picture on your left, the typical ligament that is damaged is called the ATFL. It is that front ligament that you're seeing. If you see the picture in the circle, there are three ligaments that have red parts to it. The ATFL is the one on your right. That's the most common ligament that you will sprain with an ankle sprain, an inversion ankle sprain. Now, the more severe that inversion ankle sprain becomes, the more often then you will start damaging other ligaments, and you go in a clockwise pattern from the ATFL, then down to what's called a CFL, and then in the back of that bone on the outside of your ankle called a posterior tibial fibular ligament. But the bottom line here is just for you to remember, know that this outer ligament in the front of your ankle is what everybody sprains when they have that normal ankle sprain. On the inside, when you have that eversion injury, that's where you damage what's called the deltoid ligament. Now, you may think of your deltoids up in your shoulder, but this is the deltoid ligament. It's a big, broad ligament on the inner part of your ankle. And whenever you roll it outwards, you can damage this ligament. And that's a bigger deal than the 25,000 ankle sprains a day inversion injury. So when you come to see a physician, usually you've had pain, you've got swelling, you may have black and blue. Perhaps you've come in right away, or maybe some people wait a few days or a few weeks to see if it gets better, and it really hasn't gotten better. So they come in, and the healthcare provider who sees you will do a physical exam. They'll do something called anterior drawer test, which is in that cartoon on the left, where they'll push on the front of your shin bone and pull your heel bone outwards, and they're going to look to see, do you have any instability of the ankle joint? And they'll compare it with both sides. And the idea of the instability is that if your ankle joint moves forward more than it should, then that is something that is a higher degree injury and warrants getting an MRI. So on the right-hand side here, you're going to see an MRI, and you can see labeled in red, a torn ATFL ligament. That is what the ligament looks like. It's this black line. And if you look at the arrow that's pointing to that black line, there's a white component to it. That's the tear of the ATFL. And sometimes you will see us get an MRI early. And sometimes we will say, okay, what we want to do is get you into rest, ice, compression, elevation as part of your early treatment, get you into physical therapy, where they're going to work on rebuilding the muscles around the ankle to stabilize the ankle better. They will most importantly work on what's called proprioceptive training, working on teaching the nerves to pick up when the ankle is about to roll again so that your body can stop the ankle from rolling. That's called proprioceptive training, and that's actually been shown to be very critical in decreasing the pain and long-term issues that can happen with ankle sprains. But if you go through therapy and you're still no better, then we'll get an MRI to evaluate the ligamentous structures. Now, luckily, most people don't go beyond physical therapy. Most people don't need the MRI. Most just go through therapy, resume their lifestyles, pain's better, swelling's better, black and blues are better, and they're off to doing what they want. But some people do need something more, and that something more is surgery, right? And surgery is where we're going to go in and we're going to fix the ATFL and any other associated ligament damage. So in this picture here, number 5 and number 6 is the ATFL. And what we're doing in the operating room is we are rebuilding 5 and 6, and sometimes number 10, which is coming off of the tip of the bone on the outer part of your ankle, and that bone is called the fibula. So we'll always repair 5 and 6, and sometimes we have to repair number 10. Now, the typical way to do this classically in the medical books is to do something called a Brostrom procedure, where we're going to take that tissue that's torn and stretched out, and we will cut it and retighten it. And we may reinforce it with some local tissues. Now, luckily, technology has evolved. And the whole idea here is, can we get you back to healing more reliably and healing faster? But in doing so, we can use supplemental grafts, synthetic grafts, to do it. Now, there's different types of synthetic grafts. Some are elastic, right? So if you look at this right hand bungee jumping, it's an elastic cord. It bounces back and forth. You get in the water, but you get out of the water, and there's really no harm. But there's other ones of these synthetic grafts that are not elastic, meaning they don't have any give to it. And the whole idea here is it doesn't really replicate normal anatomy. Normal anatomy in this area is a ligament that has some give to it. So we use a synthetic graft that restores stability and natural motion. It resists necrosis, so it doesn't degrade over time. But more importantly, it will regenerate natural tissue to become your normal tissue anywhere between 2 to 4 years after the surgery. More importantly, this graft reinforces the repair right from the beginning. So what we're doing here is giving you a graft, something that looks like this, these strips on the upper right-hand side here. And this histology slide is showing that this patient who had a graft 39 months before this histology slide was taken, this biopsy was taken, is now converting that graft into their normal tissue. And so that's important. You're taking something that's synthetic that reinforces you, important early in the surgery, but then becomes your normal tissue over time. So this has really accelerated our ability to get people back walking, in therapy, and at work or sport faster. So our protocol for return to walking is 2 weeks. So for the first 2 weeks, you're in a splint, not walking on it. Then you're walking on it in a boot for 4 more weeks. And then you're out of the boot and into therapy. Most people need 2 to 3 months of therapy. So my takeaway message for ankle sprains is, you want to treat these ankle sprains early. You can do it on your own, rest, ice compression, elevation as needed. But if pain persists or is really severe, or you have too much swelling, or you can't walk on it well enough, then you really should see a healthcare provider to take a look at this and see, is there something more that you need? To prevent ankle sprains before you even do any activities or before you do any strenuous activities, think about strengthening exercises, working on flexibility and mobility, working on balance and proprioception on your own. And you can do that with a variety of different techniques. And in fact, if people or listeners enjoy doing yoga or Pilates, it's a great way to work on balance and proprioception. Make sure you have proper footwear for your activities in the spring and summer. Make sure you warm up with dynamic stretching and you do some cool down at the end of your activities. Strengthen your whole lower body when you're doing your activities. It's not just about your ankle, but about your core and everything further down towards your toes. Make sure as you do your activities, you gradually progress. You don't want to just go out and run 5 miles if you've never done that. You want to maybe do a half a mile for a week, gradually go up to a mile, mile and a half, and work your way up to whatever your goals may be. Also, think about cross training. If you're a runner, you don't want to go out there and run hard every week, every day. Maybe you alternate it. Maybe you take some rest days. Maybe you cross train to do some swimming or non-impact stuff, or you do weight training. And you got to listen to your body. If your body's telling you you're fatigued, you're tired, you're cramping, listen to your body, because it's trying to signal you to stop or slow down or decrease the amount of pressure going on. All right, our next injury. This was the Achilles tendon tear heard around the world. Aaron Rodgers, his first game as a New York Jet 2 seasons ago, within the first minute of play, ends up sustaining an Achilles tendon rupture. And there was all this controversy, if you're a football fan, and that in the first month, 6 weeks, that, oh, will Aaron Rodgers come back to play and play after his surgery that season? And I'm going to tell you why that was a conversation. But let's talk about Achilles tendon ruptures first. The mechanism of an Achilles tendon rupture tends to be a sudden push off. So you're pushing off that ankle suddenly, but it's pulling upwards at the same time. That foot is pushing upwards. And that creates a lot of pressure, usually in the non-insertion part of the Achilles. On that right cartoon, I'm showing where that typical tear will occur. And that's where it pops. It's common to happen in the weekend warrior, the individual that's just playing on the weekends or at nights, common in running and racket sports, although I will tell you that I'm seeing more and more of this in basketball players as they're aging, and even in our pickleball players. The etiology of this is overload of the tendon or degeneration. And why does this happen? Well, the contributing factors being over the age of 40 years old, being male, we seem to see more of these in males than females. If you had a prior rupture, you're at higher risk. If you've had steroid injections into the Achilles, you're at higher risk. If you're on medications like fluoroquinolones or statins, you're at higher risk. Now, we see the average age of an Achilles tendon rupture about 42 years old, but I'll tell you that that is probably old data. With pickleball, we're seeing many more 60-plus-year-olds wanting surgery after an Achilles tendon rupture. So my suspicion is the average age is probably around 46 to 48 years old, given that we are seeing many more older patients wanting to remain active and get their Achilles repaired. Typically, when patients come in to see us, they will say, I felt a sudden pop, or I felt like somebody hit me in the back of my ankle, or somebody shot me in the back of my ankle, and I couldn't really walk as well anymore. So when you come to see us, we will get obviously an x-ray just to make sure there's no bony issue here, but we'll do some physical exam findings looking for a gap in the tendon itself. And we do something called the Thompson test. So we'll have you lay down on your belly, really relax your legs, and squeeze the calf muscles on both sides. And what we would notice is the injured side does not passively flex downwards because your Achilles tendon is no longer continuous. And so you don't have that flexion when you press on the calf muscle. Rarely do we get an MRI, but oftentimes patients of mine who've seen other primary care providers or in the emergency room will have gotten an MRI by the time they see us. Interestingly, this is a very interesting statistic. 25% of Achilles tendon ruptures that show up in primary care offices or in emergency rooms are missed, and they are misdiagnosed as an ankle sprain, and this patient ends up having therapy for an ankle sprain, doesn't get any better, comes to see an orthopedic surgeon and finds out that they have an Achilles tendon rupture. So if you're not progressing with what you were diagnosed as an ankle sprain the way you would like, you may want to seek outside attention sooner rather than later. Now, you can treat these with casting or boot immobilization, which is non-surgical, and that's what I'm showing here. This is a Achilles heel lifted boot where we put patients in a lift so their heel is upwards, their foot is downwards, and we're trying to take the two ends of the tendon, bring them back together as close as possible so that the patients can get a certain amount of recovery and healing in that non-surgically treated Achilles. Now, if you look at surgical versus non-surgical treatment, in terms of strength, return of strength. If you look at the literature, patients who've had surgery tend to have better restoration of strength than those who were treated non-surgically. If you look at re-rupture rates, it tends to be lower in surgical versus non-surgical treated patients. Now, some of you may go to the literature and say, well, we can find literature that shows that it's equivalent. There's a caveat to what I'm saying. If you have an Achilles tendon rupture and you're seen by somebody within 24 hours and put into that plantar flexed position and then are treated non-surgically with a extended or a rapid rehabilitation protocol, those types of patients seem to do equivalent non-surgical treatment versus surgical. In the US, most patients don't see an orthopedic surgeon within 24 hours. And so we don't get the opportunity to see that type of success with non-surgical treatment. So if you look at pro athletes, many of them will have some of these older type incisions where they've had surgical repair. They've got these big long incisions. This is Kobe Bryant's left ankle. He had an Achilles tendon rupture, had the old way of treating an Achilles tendon tear surgically. We don't do that anymore. In fact, we do mini open procedures. It's typical to what I'm going to show you here. This is a technique I developed where we make a tiny incision about 2 to 3 centimeters in length, right in the back of your tear. We'll go in and find the two ends. On the right-hand side, I'm finding the end on the upper side of the Achilles rupture. We'll put some suture across it. We'll then do the same to the end on the bottom half. And we'll pull those out of the way, and we'll open some of the deep tissue that brings better blood supply to the Achilles tendon to try to get the Achilles tendon to heal a little bit more reliably. We'll tie it in a certain pattern to bring those two ends together so that they can actually be opposed to one another. And then we do this technique called the internal brace, where if you follow this cartoon on the left side, where you can see the dark blue line, we'll put this really strong stitch from the top part of our repair all the way down to the heel bone, basically protecting the repair we did around the tear. That has changed the game for us, and that is what Aaron Rodgers had. And that allowed him to, 2 weeks after his surgery, start putting weight on it. So what we do now is, with this technique, 2 weeks after surgery, we let you start walking on it in a boot with that heel lifted boot. 4 weeks after being in the boot, where I get patients out of the boot and start physical therapy. And here's one of our NFL players who posted this on his social media. But you can see here, he's working obviously through the time of being in a boot, through his time of being non-weight bearing. And you will see that he posted it on his social media, gave me permission to share this, but you will see that he is recovering fairly nicely. Now, obviously, he's an NFL player, has access to elite physical therapists, athletic trainers, but you can see the level of activity he is doing. And this is 4 months out from his surgery that he is doing this type of activity. It's remarkable. And it's because of these new techniques that we're doing that allows patients to return to sport faster. And this is Aaron Rodgers. This was about 8 weeks out from his surgery, and he's starting to throw a football, and there was a lot of controversy of whether he was going to get back or not. So my takeaway message for Achilles tendon ruptures: it can happen suddenly. It can be career altering. Early diagnosis and treatment are critical, because we typically, if you're going to think about having surgery, we usually want to get to it within the first 4 weeks. If you feel a sudden pop or a snap in your heel, don't walk it off, seek medical attention. The way you can prevent Achilles tendon ruptures, you can stretch and do flexibility exercises, strength train, again, gradually increase your activity level, wear proper shoes that give you support for whatever activity you're doing. If you feel like you're having some tendonitis in your Achilles, maybe you wear a heel lift for a little while till it quiets down. Make sure you do a warm up and cool down, maintain a healthy body weight, and practice proper technique for whatever you want to do. So this is a common injury that we're going to talk about next, affecting the Manny brothers for a while. Plantar fasciitis was an issue that he had bilaterally, and became an issue for Peyton Manning through the latter half of his career. So plantar fasciitis is common. Most people have probably heard of it. It's usually an overuse issue, or an issue that you have become too tight over the course of your life. And most of us do get tighter as we get older. And then you have repetitive impact that can happen with running or activities that can lead to plantar fasciitis, which is inflammation of the tissue, the plantar fascia on the bottom of your heel. That tissue goes from your heel all the way out to your toes, and you can see the plantar fascia and the redness that I'm trying to show with plantar fasciitis on that right cartoon. We can see plantar fasciitis as the cause of 80% of heel pain. About 2 million people seek treatment on an annual basis, and it accounts for 1% of all orthopedic visits. 30% of these plantar fasciitis patients have bilateral pain on both sides, and this can happen typically between 40 and 60-year-olds, but we see it on the outliers as well. Risk factors include being a running athlete, having repetitive stress, prolonged standing, not wearing proper shoes, being obese, and having limited dorsiflexion. Diagnosis happens with physical exams where you're painful right in the bottom of your heel. We can get an ultrasound to look at the plantar fascia, and that's what the first two pictures are showing on the left, where there's a thickened plantar fascia and some inflammation or fluid around it. Or you can get an MRI. Typically, we don't do an ultrasound or an MRI unless patients are really having a lot of pain and they're not progressing with non-surgical treatment. The non-surgical treatment includes orthotics, stretching, anti-inflammatories, and even a steroid injection if needed. We can also do stem cell injections. Now, what's a stem cell? Stem cells have the ability to form almost any tissue of the human body, and they can be found all throughout the human body, and they can differentiate, like I said, into almost any tissue of the human body. The biggest thing that they can do, though, is they can produce proteins that affect the inflammatory system of the body. And so what you can do is take a stem cell, and it can create anti-inflammatory effects if you put it in the right environment. So you find stem cells in bone marrow and fat. The bone marrow stem cells do age over time. Smoking affects bone marrow stem cells, as do certain diseases. Whereas fat stem cells found in your abdominal fat or around your butt don't age out as you get older, and the diseases don't affect those stem cells as much, and they seem to have a higher regenerative potential rather than bone. So you can find this around obviously your abdomen, your inner thigh, and even your butt folds. The benefits of this, again, age is not a factor. We can harvest it minimally invasively. We can get those stem cells, whatever volume we need, and we can inject it into where we want. So here's a patient of mine where we are harvesting the stem cells. So here I am injecting some numbing medication into their abdominal fat. After that, we are harvesting the fat, and you can see that here, that the yellow in my syringe is the fat that we are harvesting. There are stem cells in that fat. So what we're doing next is we are processing the fat. We are micronizing it, cutting into really, really tiny, tiny pieces so that we're trying to get some of the fat to separate from the stem cells. Once we do that, we actually isolate the layer of the stem cells in the syringe, and then I will inject it, in this case, into the plantar fascia to try to give the patient relief. It's worked really well for our patients. It's not something I would do right away because patients' insurances don't cover this, but it is something that if you failed conservative care and you're considering surgery, which is the other option here, then I would try a stem cell injection before a plantar fascial release, which is what I'm showing here, an incision that's made on the inner aspect of the heel, and we are trying to release the plantar fascia and the nerve that could be compressed, giving you heel pain. So takeaway message for plantar fasciitis: heel pain in the morning when you first get out of bed might be more than just soreness. It can be plantar fasciitis. You want to start off with stretching, orthotics, and rest to try to get some of that pain to get better. And if not, then you want to see a healthcare provider. Stretching and flexibility, strength exercises, proper footwear, orthotics and inserts, warm-up activities, recovery and rest, and listening to your body are great ways to prevent this. There are some other things, including stress fractures, that I won't talk about due to time, as well as turf toes, which I won't talk about due to time. But I do want to open this up for questions. Again, I just touched upon some of the more common things you may deal with yourself as you try to get out of the hibernation months of the winter and into spring and summer. But remember, there are so many foot and ankle sports injuries that can occur. The importance is early diagnosis, early interventions to try to avoid surgery. But many of these things have surgical options if you don't get any better. So at this point, I'll open it to questions because I know we want to wrap up in a few minutes. Thanks.
Thank you, Dr. Parekh. That was so interesting. I always love seeing the professional athlete kind of behind the scenes videos.
It's pretty cool because they suffer from it too.
Yeah. Let's see. I did have, let me see. Had any questions in my email? Not sure.
Well, while you're pulling that up, I will just bring up, I do get conversations a lot about regenerative medicine and stem cells. It is an office-based procedure. It takes about 45 minutes for us to do in the office. To know if you're a candidate, obviously you're going to want to talk to your healthcare provider. But for many of us who believe in using your body to heal, it's a fantastic way to treat the itises, from arthritis to tendonitis to plantar fasciitis, and it's worked very well in our practice.
Okay. Donald, can you hear us?
Yes, I can.
You can go ahead and ask your question.
Hey, Donald.
My question is, if and by the way, I have seen a Rothman professional here in Bryn Mawr. I had an Achilles injury. It's 2 years old. I have been doing physical therapy, and I do have a cyst that was diagnosed in the ankle. And so the question is there a solution for me? Because I am in daily pain. I have trouble walking on the ankle. And I don't know where I go from here.
Yeah, so I won't be able to obviously I don't have access to your records, and I wouldn't be able to offer you specific patient advice over a social media or
I accept that.
But what I would say in general is you probably want to make sure you see one of the foot and ankle providers at Rothman. Getting if it's been a while since you've had imaging, you may need new imaging to update to see the condition of your tendon or the cyst, and then talk about options that might be possible for you. And whether it's myself or whether it's one of our other colleagues in our foot and ankle division at Rothman, all of them are extremely well versed in many of the pathologies around the foot and ankle. But that's probably what you want to do if it's been a while since you've
But I
had
guess
imaging.
if I can interrupt, the real question is if I'm 2 years post injury, and is it something I'm going to have to end up living with, or is it something that can be handled?
Yeah, I mean, a lot of the devils are in the detail for something like that. So I would say in general, there are certain things, and I don't know exactly your condition again, but there are certain things where people have to learn to live with it. But the vast majority of things we can fix, especially if there's a mechanical issue that's going on. The vast majority of those things we can fix and get patients better from where they were.
Okay, thank you. I appreciate that.
Yeah, you're welcome.
Okay, and we have a couple more questions in the Q&A there.
Sure.
I don't know if you can see them.
Yeah. Can stem cell therapy be used successfully to treat knee joint OA and avoid total knee replacement? So I've had very good success with knee arthritis injections of stem cells. I've done that in a number of patients. I tell patients that we're not curing your arthritis. Think of it as we're just trying to prolong the need for a knee replacement, right? So if you've had steroid injections and that failed, no longer works for you, or if you've had some of the hyaluronic acid injections and that hasn't worked for you anymore, and you have mild to moderate knee arthritis, I would tell you that I've had good success for patients getting stem cell injections. Once you get to the severe level and you're on bone, I don't think there's really any more role in the stem cell injections. And again, the idea here is we're not avoiding the knee replacement, but we're delaying the need for it, maybe the rest of your life, or maybe a few more years. We're just trying to buy time for you. I hope that answers your question. The other question is, a stroke patient loses dorsiflexion and plantar flexion. Does stem cell work for it? That's a really complicated answer. I will tell you my perception of this, okay? So when you're talking about a neurologic reason to lose motion and strength, I think that's probably in the realm of talking to a neurologist to see if there's some options there. I think the stem cell injections work great when we're dealing with local issues, the itises, arthritis, plantar fasciitis, tendonitis, things that are local where I can inject it right where they need. For stroke, it depends on where you've had your stroke, where it's affecting it, what sides. It's a lot more complicated, and that wouldn't be in the purvey of an orthopedic surgeon. So that's something that I think you would need to talk to a neurologist about. Hope that answers that question. Next one is, what is the treatment for an old injury break that was misdiagnosed? 10 years later, the break was identified and the ankle was scoped, cleaned out with lots of bone fragments. 10 years after that, it collapsed. I was put in a fusion boot. It's now always painful, swollen, pronounced ronate. I'm not sure what that is. Rotation, maybe. So obviously, I think you need to be probably seen by a orthopedic foot and ankle surgeon. Get evaluated, probably get a CT scan, maybe an MRI to get a better idea of what's going on. It sounds like you may have had some arthritis, and there are a lot of different options for patients who have arthritis. If you've had collapse from something called avascular necrosis, we now have 3D printing that we have helped to pioneer here at Rothman that can give patients options to maintain motion and not need a fusion. So I would recommend that you probably see one of our providers in the foot and ankle division to get more insight as to options you may have that are current, especially with technological changes. Next question, I had ankle pain and an MRI showed that my tendons are okay, but there's bone marrow edema. I was given a nice brace and told that rest would help. It hasn't. Can something else be done? So bone marrow edema is an interesting thing depending on location and depending on severity. Sometimes non-operative treatments can be helpful depending on the bones involved. Sometimes patients can get a bone stimulator approved by insurance. Sometimes you need vitamin D optimization. Sometimes you may need an endocrinologist to get involved. And sometimes you need surgery where we go in and we inject some of the stem cells, like I was talking about from your bone marrow, injecting it into the area to help stabilize the bone and encourage it to heal. So again, I would recommend seeing one of our foot and ankle providers at Rothman, who could probably give you some insight as to options you may have for bone marrow edema. Next one, the 601 question. Does that mean the patient has foot drop? I don't know, it's possible, but they were talking about ankle dorsiflexion and plantar flexion, so I'm not sure if the patient, the neurologic stroke patient, had a foot drop, but it's likely that they did. Next question. I strained a tendon in the outside of my ankle last August. Although the pain is now gone after using an orthotic and physical therapy, I still sometimes feel a small movement in the tendon. Is there something that can be done to stabilize the tendon? Yeah, it depends on the tendon you're talking about, the location of the tendon. If you're talking about tendons on the outer part of your ankle, there's something called subluxation of the tendons, where the two tendons that sit one on top of the other are actually popping on one another. If that is irritating and painful for you, there are some surgical options that can be done. Again, something worth discussing with a foot and ankle provider here at Rothman to A, do the proper workup for you in the exam, and then B, talk to you about options for care. Treatment for chronic plantar fasciitis in both heels. So that's an interesting question. If you have chronic plantar fasciitis in both heels, 10% of those patients have an underlying issue with their inflammatory system. You probably need to see one of our providers who could order a rheumatologic panel just to do some generalized screening for you. If that comes back positive for something, you then need to see a rheumatologist. If it's not positive for anything, then you talk to them about options for non-surgical treatment and potentially even surgical treatment. But again, that's going to be very individualized depending on your physical exam and your findings on imaging. Next question is partial tear of Achilles from heel bone, no treatment for 2 weeks, then boot and PT, enlarged, remains 20 years later. Any way to reduce chronic scar bumps remaining? So scarring, so it really depends. This is an interesting question. If you have any loss of motion or strength from a partial tear, perhaps that needs to be attended to and managed. If it's just scarring and that's really painful or problematic with shoe wear, there are options, although they would require some surgery. So again, seeing one of our providers to talk to you about options and recovery times would be important. I think I got them all, Kristen.
Wait, there's one more.
Yeah, no, I'm here.
I had ankle pain and the MRI showed that my tendons are okay, but there is bone marrow edema. I was given a night brace and told, did you see that one?
Yeah, I think I got that one. That was the one.
Oh, okay. Oh, sorry. I thought I
Yeah, no worries.
erased them. Oh, here's
another
one more popped up.
What recommendations are there for a heel bone bruise as a result of wearing ice cleats for 3 weeks on snow? Wow. Ice cleats leading to bone bruising. We see that even with rock climbers where they get these bone bruises. Depending on painful they are, vitamin D optimization, immobilization in a boot for a period of time. It depends on location, it depends on severity, it depends on a number of different factors. So again, seeing one of our providers would be important. But it can take up to 3 months for a bone bruise to really quiet down. Again, depends on location and severity. Sometimes the bone bruise leads to a crack in the shell of the bone, and then that sometimes needs even further intervention. So making sure you see somebody would be nice and important. If we have time, might you review shin splints? So shin splints are basically, think of it as inflammation of the bone because of where the muscle sits attaching to the bone. That muscle keeps tugging on the bone and leads to inflammation of that insertion of the muscle right on the bone. And typically what we do for patients like that is cross training. So typically I see shin splints in runners or my soccer players because they're out there running so much. And so what we will have them do is there's a heavy day and a light day and a cross training day. They'll use anti-inflammatories and physical therapy and topical creams, all of which is to try to get the shin splints to quiet down. And you do want to take shin splints seriously. You don't want to just push through it because it can lead to bigger problems like tibial shin bone stress fractures and even tibial fractures. So it's important to understand that. Thank you for the comment on understanding and understanding treatments. Which gender is more common in plantar fasciitis? So we tend to see more women than men. Why? Don't really know. But my suspicion is that hormone changes as you get older tend to be more dramatic in women than men, and that probably plays a role in the plantar fasciitis. But we typically see plantar fasciitis over the age of 40, typically overweight, more often in women, more often in those who are tighter. And so that's something to consider as we're treating patients and addressing the things that are addressable. Next question is, are flat feet and fasciitis related? Great, insightful question. They can be. So people who are really flat-footed can be very tight in their Achilles tendon, and by being extra tight in your Achilles tendon, that can lead to tightness in the plantar fascia and some plantar fasciitis. So they can be related, but you typically don't see that in mild flat feet. You'll see that in more severe flat feet. Boom.
I think we got to the end.
Awesome.
Well, listen, thank you so much for doing this. And for everybody that was able to join us, this, like I said in the beginning, this will be emailed to you within about a week. And I have my contact information in the chat, and you guys all also have my email. So if you have any additional questions, or if you would like to schedule an appointment, you can reach out to me directly.
And thank you, everybody, for listening. Feel free to drop questions or come by and say hi.
All right. Thank you, Dr. Parekh. Good night, everybody.
Good night, everybody.